DS is a 21-year-old male presenting to the ED with left-sided abdominal pain, nausea, and vomiting. Patient describes the pain as non-radiating, sharp, constant left lower quadrant pain. Patient at the time of admission says his pain is completely resolved and is wondering when he can eat and drink. On physical exam, he appears sleepy, ANO times 4, regular rate rhythm, lungs were clear bilaterally, abdomen non-tender, non-distended, no organomegaly, and the skin is intact with no visualized rashes. For a review of systems, general was negative for fever, chills, sweats, and fatigue. Eye was negative for redness or eye pain, no recent visual problems, and negative discharge. Respiratory, negative for shortness of breath, cough, sputum production, wheezing, and pleuritic chest pain. Cardiovascular was negative for chest pain, palpitations, and peripheral edema. For GI, it was positive for nausea and vomiting, but negative for vomiting since arriving at the facility. No diarrhea, no constipation, heartburn, and no abdominal pain currently. For musculoskeletal, negative for back pain, joint pain, muscle weakness, and joint swelling. For the skin, negative for rash, pruritus, dryness, and skin lesions. And then for neurological, negative for weakness, numbness, dizziness, and headache. Patient's past medical history includes insulin-dependent diabetes since 2021 and hypertriglyceridemia. Past surgical history is significant for a tonsillectomy, and he has no known allergies. For family history, his mother and grandmother are diabetic. And then social history, patient does not smoke, drink alcohol, or do any other drugs. Abnormal labs for the patient. On admission, patient is hyperglycemic, 352, hyponatremic at 128, hypochloremic at 92, and he has a direct hyperbilirubinemia of 0.7 and a high total protein. Day 1 of admission, he has a slight leukocytosis of 11.1. He's still hyperglycemic at 221. He has a low BUN at 5, and then still has a direct hyperbilirubinemia of 0.7 and a high total protein of 5.8. He has a high osmolality of 305, a high cholesterol of 938, a low HDL of 11, a low LDL of 20, a high triglycerides of 4,157, and a serum turbidity of 4+. On day 2, he has a normal CBC. He's hyperkalemic of 5.3, and he still has a high triglyceride level of 2291. On day 3, he has a normal CMP. He still has the high triglycerides at 1442. And then on day 4, normal CBC and CMP and a high triglyceride of 945. Then day 5, normal CMP and a high triglyceride of 732. Day 6, normal CBC and CMP, and he has a high triglyceride of 770. For our differential diagnoses, they were perforated peptic ulcer, gallstone pancreatitis, hypertriglyceridemia pancreatitis, or autoimmune pancreatitis. Patient had a CT done while he was in the ED, and the CT showed peripancreatic fat stranding, like the example shown below. So the final diagnosis for our patient was hypertriglyceridemia pancreatitis. As you can see, the levels of his triglycerides were super high. Actually, they were so high on admission that the lab could not read them. It was above 4,500, which is the max value for that lab. So they were having trouble reading that lab, and then finally on day 1, we could start finally getting an accurate read-in. The risk for acute pancreatitis caused by hypertriglyceridemia significantly increases when the levels are above 500, and it increases even more when they're above 1,000. And in our case, our patient was above 4,000, so he was at severe risk for this. It's caused by a reduction in LPL from either gene deficiencies or regulators. Commonly presents with symptoms of acute pancreatitis with elevated lipid levels. The diagnosis of acute pancreatitis is made with 2 of the 3 following: the epigastric abdominal pain, radiating to the back, and then or 3 times elevated lipase or amylase levels, and characteristic imaging findings for pancreatitis. Our patient had the abdominal pain and the classic imaging findings for the pancreatitis to diagnose him. After making the diagnosis, you then look to see what's causing the pancreatitis. And in our case, it was pretty interesting to see that his triglyceride levels were that high and caused this. And then you can either treat with plasmapheresis if the levels are super high, or insulin therapy, and then just correct the electrolyte imbalances. For our patient, he previously had the plasmapheresis and he did not want to do that again. So we elected to do the insulin therapy and titrate his triglyceride levels down, and also watching his glucose levels and potassium levels as well. And the reason it's called birthday discharge is due to our patient being discharged on his birthday, so we were able to get him out and home safely in time to celebrate with his family.